Top Med Talk.
Today's Top Med Talk is a two-part piece. This is part 1 of 2.
So this particular session is entitled Fitness, Function or Frailty. Now, we're all very interested in this whole subject area. We've recognised throughout our careers, throughout our lives, that fitness, function and or frailty are important determinants of the quality of the life that we live. And in the context of major surgery, we think it's highly pertinent, highly relative. So I really enjoyed watching all the long-form lectures that you can access via our e-learning platform. But the one, as a complete non-expert in this area, apart from someone who's becoming less functional, less fit and more frail, is there's a lot of chat about how to describe it, who should describe it, that it relates to certain outcomes, but I hope we can add an extra F to the discussions as we go through the next hour. And that is there anything in all of these descriptors that we can actually fix and make a difference to outcome? So, Scarlett, McNally, sorry to hand the ball straight to you with that little challenge as the actual chair of this session. I'll be quiet now for a while and come back in when we have questions from Slido. Scarlett, welcome.
Yes. Thank you very much. So I'm Scarlett McNally, consultant orthopaedic surgeon and deputy director for the Centre for Perioperative Care. So do look there to look for all our resources for patients and staff in this area. And I'm really delighted with that fix idea because as an orthopaedic surgeon, that's what we like to think we do best. I've spent many years trying to fix patients with hip fractures, for example, and fitness, frailty and function are the key determinants of outcome, really. So just to remind people, you can look at the talks right up till the 9th of July. They were really amazing talks and full of information. So do go back to those and look for detail. I think this is what we need to build the business case to change what we do, because better care is also more cost effective, more efficient, and gives you a much more empowered patient, and the workforce feels much better with it as well. So I'm going to introduce each of the panelists in turn, and but also just say what I took out of their talks. And bear in mind, it's a very mixed audience, as there is with perioperative care. So sometimes it's a question of trying to distill key messages so you can get the others on board to build the service that you need that really should be multidisciplinary and across professions. I wanted to start with Dani Levitt, and it was a fantastic talk. And it's particularly that the message about you can change things. There's a huge amount of being able to measure things, but that never too late message and the second insult, and that surgery is part of things that patients have to adapt to, and each one might have a worse outcome because of what went before. So, Denny, do you want to just introduce yourself and say anything else from your talk briefly that you think people should have got out of it?
Yes, my name is Dani Levitt. I am a professor in perioperative medicine from Southampton in the UK. I'm also the clinical lead for our perioperative medicine service and our post-operative level 2 surgical critical care unit. And my particular research interest is in the area of fitness for surgery and prehabilitation. I think the key messages I'd like to get across from this session and try to get across in my talk is the first thing is to say that fitness, frailty and functional capacity are clearly overlapping concepts. And I believe and agree with something that Jude also said in her talk, which is I think there is enough data now to say that if you are frail or have low functional capacity or have low fitness, you're going to have a worse outcome after surgery. And as Monty alluded to, I think the key going forward for us as perioperative physicians is how and what of that is modifiable and how much of that takes part in shared decision-making because the risk factor is not modifiable. And that we need to focus on seeing patients early in the journey so that we have the time to address either their frailty or their fitness with interventions that are evidence-based and have been shown to work. And I think really importantly, just addressing fitness on its own without looking to psychological factors that affect healthcare behaviours is unlikely to be effective. And the other point that I'd really like to make is that, physical inactivity is a massive public health issue, not only for us, but for the next generation even more so. And we should be ambitious and see this teachable moment when a patient has a new diagnosis and may, in fact, for the first time in some time, look at their health behaviour to really try and affect not just the outcome from their surgery, but their longer-term health outcomes. Because it is a teachable moment. We've seen this particularly in cancer, where people suddenly address their own mortality and might change those healthcare behaviours which do determine their outcomes. So those are the points really I wanted to get across.
Moving on to Daniel Conway. Again, yours was a very interesting talk, and I got a lot out of it in terms of ask an expert, use the therapists, but also that although there are some very complex tools for assessing function and functional status, there are also some simple things that we can use. So obviously as a surgeon, I was quite keen that we could find something that almost that everyone can use. And I was particularly struck that a lot of the surgery we do is to improve someone's function, and therefore we need to know what it's like to begin with.
Thank you, Scarlett. So my name's Daniel Conway. I'm a consultant in anaesthesia and critical care at Manchester Foundation Trust in Manchester in the United Kingdom. I'm also the course lead for a Masters in Perioperative Medicine programme at Manchester Metropolitan University, and I'm the group lead for perioperative medicine for our Foundation Trust across 4 hospitals. So it's a great honour and an interesting journey looking into the concepts around function, because as you said, it's something that in many ways doctors aren't particularly experts at, and we often do defer to our colleagues who are trained in this, physiotherapists and occupational therapists. And yet the evidence is really quite strong. People with limitations in their functional state have significant challenges when they undergo major surgery. And one of the key elements is, although we talk a lot about cancer surgery and how important that is, but actually the purpose of much surgery these days, and even some cancer surgery, is to improve quality of life and functional state rather than longevity. And therefore, understanding an individual's functional status and what they're able to do before you embark on surgery is really important. And that obviously is already happening. People will see physiotherapists before having joint replacements, for example. And yet often that information isn't particularly well shared amongst the team. And therefore, improving communication between patients and therapists and patients and their medical carers, as well as within the team, can really enhance what we're trying to do and help patients and everybody else in their family understand what we're trying to achieve. And as you say, it turns out there are some fairly simple tools that you can use. It doesn't require a very intense period of observation to understand a person understand their functional state as well. And one of the things that I thought was really important, that I'm glad that I spent some time talking about, was around cognitive function, because again, that's often overlooked. It's as long as somebody's not got an obvious sort of diagnosis of dementia, we tend to assume that they're cognitively fully intact, and often there are shades of mild cognitive impairment that then rears its head in the perioperative period and causes patients and their families a great deal of distress and can slow down the recovery for those patients. So that was really what my talk was about. And one thing that I probably would like to talk a bit more about, because I didn't have time, was using functional status as an outcome as well. So you'll be aware that in the UK, patient-reported outcome measures have been used for hip and knee surgery, but actually generic tools like quality of life and the WHO disability assessment schedule can be used to look at how well people have done after surgery, and that's maybe a good quality marker rather than simply looking at length of stay or mortality. So I think functional state has a lot to offer in helping us improve care for patients undergoing surgery.
Brilliant. So moving on, Judith Partridge gave a brilliant talk on frailty. And I think this is something that some people grapple with, not really understanding how to explain it almost. And it was a very helpful talk. And also the fact it coincides with multi-morbidity, and that there are things that people can do to improve their frailty scores. So can you introduce yourself and tell us the key messages you were wanting people to get out of your talk?
As you say, I'm Jude Partridge. I'm a geriatrician at Guy's and St Thomas's in London in the UK. working within the POPS service, so that's perioperative medicine for older patients undergoing surgery. And I also have a role in the British Geriatrics Society chairing the POPS specialist interest group there, with research interest in many of the things that the panellists have been discussing. So how can we try and improve outcomes for this older, frailer, multi-morbid group using health services type research, and also looking at frailty and cognitive impairment in the perioperative setting. So I think it's very nice the way this session has joined up these interlinking concepts. And I think within my talk, I think it is important that we're a little purist in what we mean by frailty, and that this is a discrete syndrome which we have a definition for, but very much that, of course, frailty doesn't exist in isolation. And it also has an overlap with multimorbidity, with sarcopenia, very importantly when we're looking at the research literature, probably also with the cachexia that we see in cancer, in heart failure, and in other conditions in older patients. And then, of course, with an impact and a cause from both fitness and function, as we've heard from the other panellists. And as Denny said, and as we discussed in our sessions, we know that frailty is bad for you, whether that's in the context of COVID, whether that's in the context of being admitted as a medical inpatient with another pathology, or whether that's in the surgical context. But what we do now need to do is try and move to looking at how we can best address and hopefully modify this syndrome so that we can improve post-operative outcomes in this older, complex group of patients.
Brilliant. And we've got Vicki Morton.
Sure. Thank you. So I am the Director of Clinical and Quality Outcomes for an anesthesia group in North Carolina, and I'm also a nurse practitioner, so I have some clinical responsibilities as well. But my main role is to really oversee our enhanced recovery program within the hospital system. Really what I think that people need to get out of this session is bridging that gap between the patient needing surgery, going to surgery, and really what's doing the best thing for that patient, and understanding the entire picture for the patient, and not just the fact that they need this surgery, looking at all components of their life, looking at their frailty, looking at their nutrition status, looking at their functionality, looking at their cognitive capabilities at the time, and what can we do as the care team to improve their outcome, not just by doing a good operation, but making sure that we're covering all of our bases and making sure that these patients are in the best possible state that they can be in prior to us bringing them into surgery.
And it's great to have an international panel and an audience, because this is basically how to do surgery well, to get the whole team involved and get the patients as good as they can be. And sometimes if the discussion, shared decision-making works with the patient to make the right choice in the end.
I think when I think about perioperative medicine, and obviously we're talking about today with function and frailty and fitness, I think as we've seen over the few days, it's about multimodal, first of all screening and then assessment, and then needs-based interventions that are really important. And with frailty, there's the element of it which is to do with comorbidity. So people whose comorbidities are managed poorly or could be optimized, you may optimize their functional status by optimizing their comorbidities. And that may be with a CGA, optimizing medications, reducing polypharmacy, other sort of elements. It may be, as Jude alluded to, there's a patient with sarcopenia. And some of those patients, that may be because they're nutritionally deficient. And so in those patients, their optimization program actually may be less focused on multimorbidity, because some frail patients aren't multi-comorbid. They just have reduced function, and it may be nutrition is very key, and a nutrition stroke exercise program. And as Daniel's alluded to, other people, it may be that their main risk from their frailty may be cognitive, and how we best reduce their risks and manage them during their hospital stay for delirium, which will impact long-term outcome. What's key to my mind, and where we really have to focus on managing perioperative medicine, is addressing the pathways so that we can see patients early enough to do the assessment, so that we know what their needs are, so that we can intervene with the package. It's not about one intervention that's going to be a cure-all for everybody. And I think it's the needs and the right people will be able to deliver the package that's appropriate for that individual.
Monty, do we have questions on the Slido?
So I think the first one, which segues nicely from Denny's point there, giving an opportunity to evaluate people preoperatively, and this has received the greatest number of votes so far. We struggle to see 8 patients per anaesthesia clinic session, 2 anaesthetists, 1 PAC nurse and a pharmacist. How many appointments / hours does it take each of you? And I'm going to take that also the fact is you want lots of time to evaluate well in advance. What's the resource limitations in that?
Well, in our institution, we try and do an early screen with some questionnaires. And at the moment, things are very different because of COVID, and we're doing very little face-to-face pre-assessment or perioperative medicine, and we're just transitioning back. But it's early screening with questionnaires to identify an at-risk population. We happen to use DARSI for physical activity. We've used the Edmonton Frailty Score, but also use a transitioning because, as Jude alluded to, the clinical frailty scale seems to be where we're moving to nationally. And we use a perioperative nutrition screen to screen for nutrition. And we actually have used the clock within the Edmonton Frail Scale as an initial screen for cognitive dysfunction. And so that's a relatively short screen, which allows you, before the patient comes to see somebody, to see where their main needs lie. Going through that screening process is about half an hour to, depending on some patients, it's 5 minutes. If everything's green, it's quick. If everything's red, it may inform a bit more digging, but up to we've averaged it out about half an hour of pre-assessment, and that can be nurse-led time. And then for the small group of patients that are red on everything, we bring them in for a high-risk assessment consultation. And there depending on where their needs lie, they'll be seen by the professionals in a multidisciplinary clinic. So in all, a very high-risk patient may need an hour for a one-on-one face-to-face, as I believe is similar with other face-to-face. It takes about an hour to go through that, prescribe it needs-based prehabilitation, do the risk and shared decision-making, and planning. So about an hour, I'd say, face-to-face. And often after the hour, 20 minutes speaking to various other members of the multidisciplinary team to make sure that plan is integrated. But I think the key is that there's only 5 to 10% of our patients that need that. If every patient needed that, we'd become overwhelmed immediately. But there are many patients who are green. We have a green, amber, red system for everything. And then it's good because you have a list of patients who are ready to go. And if there's any short-term cancellations, they can be on that list. And the amber ones are off having prehab or giving up smoking or losing weight or doing whatever. And what they're doing in that amber to prehab time depends on the urgency of their surgery and their needs. Because if it's cancer surgery, clearly timescales are narrow. If it's joint replacement, there is no excuse for not optimizing their chronic health conditions properly before we operate.
So in our perioperative clinics, we see a lot of patients, resources are lacking for sure. And what I find when I'm in the clinic, we try to do all of the right things. We assess the patients. We do use a frailty scoring system. We do nutrition scoring. But then the big question is what do we do with that? And what is the communication out once you have that information? And that is where we are lacking. And I think it's a couple of things. It's number one, lack of education and knowledge from the clinicians that are in the clinic and providing the assessments and not knowing what to do with that information. But then also it's our system and not closing that gap and providing the tools necessary to put the information that we've gathered now out to the care team. We, put the information out that the patient has a cardiac history or a pulmonary history or bleeding issues or labs that are abnormal, but we don't have a mechanism to go and communicate out that the patient has scored poorly in frailty or their nutrition screen is at-risk nutrition for this patient, and what do we do about it? So you can do all the right things, but then you have to make sure that you have a plan in place to actually address what those issues are moving forward. So that's where our resources lack.
You mentioned the fix earlier, and I think that's what you're describing, isn't it? Is that the assessment and the description of risk we're perhaps all getting very good at, but the fix we're not so good at. And Within the POP service at Guy's and St Thomas's, we use comprehensive geriatric assessment. And where that term CGA is lacking is that actually the entire evidence base around CGA actually comes from the targeted optimization of that patient that follows the assessment process. So it's a very misleading name to call it just assessment, when actually what it does is it prompts an optimization of all identified issues. And given that these patients are multimorbid and often have a multi-domain syndrome like frailty, the interventions can be very varied. So as physicians, we obviously take on the optimization of their heart failure, the management of their anemia, the investigation of their new renal failure, etc. But the therapists within the team will very much start to address that functional part that might be more limited in patients, and start to, as Denny describes, prescribe targeted exercise, or look at the patient's home environment and see how that can be optimized in order to make that process through surgery smoother. So I think that's the bit that's very important, and that's the bit we need to explore more in research studies, is how a multi-component optimization package can impact on outcome.
Dani, I think you were going to come in.
One thing that I think Denny's touched upon, and is probably the way I think about it, is it's a bit like Maslow's hierarchy of need. You've got this pyramid, and at the bottom of the pyramid, with a big base, are probably relatively fit people who are coming for surgery, who will benefit from advice, who will probably take that advice and need little specialist intervention. So they can often be assessed either online or with telephone triage, for example, by relatively experienced members of staff, or not multidisciplinary specialties. And as you work through the pyramid, patients need more and more intervention, but fortunately there are less of them. And that would apply in terms of the fix. For a lot of patients, what we're talking about is prehabilitation. So for prehabilitation, a lot of people at the bottom of that pyramid will already be doing the right exercise and nutrition and such like halfway through in less people, but they can go to more generic exercise classes that can be set up for them. They can follow online classes if necessary. And then, right at the top of the pyramid, the really complex patients with high needs, they need probably one-to-one interventions with a personal trainer or a physiotherapist and a dietitian appointment and all those things. So I think, to answer the person's question, we've only got 8 slots per day. Was it per day or per session?
But actually, per hour, I thought it was.
Who are you seeing? My question is, who are you seeing? Because you don't need that MDT to see the majority of patients, but you need a system where the right patient is seen by the right members of the team in good time, so that an intervention can be made if necessary.
So, Scarlett, I'll invite you to comment on this, and I then think Denny wants to come back in, and then I have a proposal for getting through the 36 Slido questions we've accumulated.
I just wanted to pick up on some of that. That's really good, because what we actually need to do is, as I said before, create the business case for this working. And actually, if you see it as a pyramid or a green, amber, red system, then you can almost justify the resources that are needed for the high-risk patients by showing that you'll reduce complications, reduce cancellations on the day, reduce lengthy post-operative stays. And you can use that as the business case to get the whole system in place. So some people will start small with kind of just almost upskilling the basic patients, and some people will be able to build on that to get in the resource-intensive service that the very high-risk patients require.
I think Denny wanted to come back in on that point.
Just wanted to, it might sound like I'm harping on a bit about this, but pathways are really important here. In elective orthopaedics, you often have an 18-week waiting time, and that is a massive luxury to be able to get these things, that get their anemia sorted, optimize their diabetes. You've got a reasonably long time for functional assessment. But I think if you're starting with perioperative medicine, in order to see the right patients, as Dani alluded to, you need to find out how a patient gets onto an operating list and how you can get involved in the pathway before they've got onto that operating list. And actually, for cancer patients, that's often at the time of, or depending on the type of cancer, before the MDT. And the key as a perioperative physician, I think, is understanding that you need to map the pathway for each specialty that your team is going to be involved in, because they all come in different ways, and it's different in a tertiary referral centre. You then have the challenges of patients coming from a long way away. But then trying to engage your surgical teams in thinking of you early on when they hear at the MDT that someone seems to have a long list of comorbidities. Because if we get involved, then we have more chance for these interventions. But if we get involved after the decision's been made at day 54 in the 62 target, which is what we have in the UK, you're meant to have treatment 62 days after a referral, then the pressure to proceed and the concerns about delaying surgery means that we do proceed sometimes with patients who are not appropriately optimized.
Top Med Talk. Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.